Good afternoon, everybody. Yeah, my slides are there. So this is building up upon our lovely panel discussion. It was a very lively discussion. Now we're going to talk about what else can we do in second line. So we've already covered this. We know that three-year survival or even 5-year survival, even though we're seeing some outcomes as compared to earlier, it is still quite low. And we do want to figure out ways and means to increase survival of patients even more. Coming to the interplay between PD-L1 and PAR, this is where this trial is leading, is that we know that PD-L1 expression is not very high in patients with SCLC tumors, and PAR, although is very highly expressed in SCLC, there were preclinical studies which showed that there might be a synergistic efficacy of combining these drugs together, because PAR leads to STING pathway activation that increases T cell infiltration. They potentially upgrade PD-L1 expression as well. And again, studies showed that there was some preclinical data with regard to the combined efficacy of these drugs as opposed to either alone. So this study, the phase 1-2 MEDIOLA study, it was a signal-seeking study assessing the safety, tolerability and anti-tumor activity of Durvalumab in combination with Olaparib in patients with metastatic or recurrent solid tumors. So they took 4 tumor types. One was of course SCLC, the other one was breast, patients who had germline BRCA1 and 2 mutations, ovarian cancer associated with germline BRCA1 and 2 mutations, and gastric cancers. The other results have also been published. Coming to the trial, it was an open-label, single-arm, multi-center, international basket study. Patients 18 years or older with relapsed, limited or extensive stage SCLC who were platinum sensitive. They were included, and the relapse had to be more than 12 weeks from the last chemotherapy. Good performance status, and notably those patients who had not received immunotherapy or any PARP inhibitor combination previously. So the SCLC cohort, there was a run-in period where they gave Olaparib for 4 weeks. Then they reassessed the patient, and those patients who had not progressed, then they gave them the combination of Olaparib and added Durvalumab 4 weekly until disease progression, and then CT scans were done every 8 weeks. So patients who were doing well could discontinue either or of the study drugs if they had adverse events, and treatment beyond progression was allowed. Primary endpoints mostly was safety and tolerability and DCR at 12 weeks. Secondary endpoints were DCR at 28 weeks, ORR, duration of response, PFS, OS, tumor percentage change from baseline at both 12 weeks and 28 weeks, and some biomarker subgroup analysis as well. When Nano PD-L1 SP263 assay was used, and they looked at PD-L1 expression in both immune cells and tumor cells, and cutoff was set at 1% or higher, and they looked at different cutoffs. Tumor mutation burden was also assessed by Foundation Medicine, and more than 20 mutations for megabase was considered high. 6 to 20 was intermediate, and less than 6 was low. So the trial premises was, if they looked at historical data, this study used a target median PFS of around 4.4 months and targeted a DCR at 12 weeks of around 60%, for which that is when they would have said that it's a positive trial and gone ahead. A DCR of 40 or less was considered undesirable. Looking at the patients, between 2016 May and December, 64 patients were screened and 40 patients finally were assigned to treatment, out of which, if you look at the red boxes, most of the patients who discontinued treatment, I'll come back to that later, were because of objective disease progression in both Durvalumab related to Durvalumab or Olaparib, and around 38 patients were finally included in the analysis set, so it was a small patient data. Most patients were between 44 to 76 with a median age of around 62 years, and 71% had received 1 line of chemotherapy, and around 28 to 30% patients had received 1 or more than 2 lines of chemotherapy, and around almost 80% patients had received radiation to the brain, and most patients had extensive disease, and around half of patients, 50% of the patients nearly had less than 6 months of time to progression after completion of platinum-based therapy. As per efficacy, so the DCR at week 12 was around 28.9%. So this was lower than the pre-specified investigator assessed target DCR of 60%. This was considered a negative study. 4 patients had an objective response, around ORR was around 10.5%. There was 1 CR out of these. And all of this occurred after the first 4 weeks of Olaparib monotherapy. So it was driven by Olaparib and kind of maintained by Durvalumab. That's what these investigators wrote. And coming to median PFS was 2.4 months. And there was no difference in PFS in those patients who received previously 1 lines of chemotherapy or 2. And median OS was 7.6 months, which is kind of comparable to previous data of patients with SCLC in the second line. The investigators also looked at best percentage change in target lesion size for each patient by number of lines of previous chemotherapy, and there was no relationship. I've mentioned this before. Patients did go on to receive multiple lines of chemotherapy, some mostly topotecan or carboplatin etoposide. Coming to biomarkers, so no significant correlation was observed between archival tissue PD-L1 expression and any of the response rates or the criteria. No significant correlations could be made regarding TMB and clinical outcomes. The sample size was very small. 1 patient had a BRCA mutation, however, did not really respond. And they analyzed the NGS as well. So TP53 and RB1 were the most frequently mutated. MLL2 and KMT2D was also the second most common gene mutation, and amplifications in the IRS2 genes were seen in those patients who experienced early disease progression. Other gene mutations were not very common. Coming to safety, safety was by and large similar to what has been noted as single agent trials for the same agents. So for Olaparib it was anemia, nausea, fatigue, and there were grade 3 and grade 4 AEs. Discontinuation rate was around 15 to 20% for patients because of adverse events. And the authors concluded that although the 12-week DCR did not meet the pre-specified target, I'm almost done. 4 patients responded and median overall survival was promising for the pre-treated SCLC population. The regimen of Olaparib for 4 weeks followed by addition of Durvalumab was consistent with known safety profile of the 2 drugs as monotherapies, and we need further data to identify that subgroup of patients which will likely benefit from this treatment approach, and more research on how to improve outcomes beyond the first line setting. So I don't have time. Quickly, the combination of PARP inhibitor either as single agent or in combination with chemotherapy has been studied previously. The gist of it is that single agent PARP inhibitors show some response but not enough. Combinations show good improvement in overall response rates, however has not really led to a PFS and OFS benefit. And we know that there's a certain population of SCLC patients which may respond to this, and we need to find out what population that is. So we need to look at biomarkers. Studies have looked at SLF and 11. We need prospective validation of that. We also need to see which of the molecular subtypes of small cell cancer we know that inflamed subtype usually responds well to immunotherapy, would respond to the combination. And I don't think this is the end for PARP inhibition because there seems to be some activity. Now they're trying PARP inhibitors with combination with different agents. As mentioned before, I think there are trials with ADCs also coming along. So, thank you.